Today, we'll be continuing from where we left off with the pelvic inflammatory disease topic. I'm going to start from the classification, the Gainsville classification. We have stage 1, which is early salpingitis, tenderness localized to the adnexa. And we have stage 2, which is late salpingitis and pelvic peritonitis. Stage 3 is evidence of pyosulfings. There is a tubo-ovarian mass and tubal occlusion or an erythrocyte sedimentation rate of more than 60 milliliters per hour. In stage 4, it's a ruptured tubo-ovarian complex with generalized peritonitis and septicemia. In the old Gainsville classification, it was up to stage 5, which was adult respiratory distress syndrome, but it has been updated and now ends in stage 4, which is just the ruptured tubo-ovarian complex with generalized peritonitis and septicemia. So diagnostic criteria and guidelines of PID: the patients with pelvic pain and tenderness, as well as one of the following, are referred to as confirmed cases. So there must be acute or chronic endometritis on histological evaluation, a demonstration of chlamydia, trachomatis, or gonorrhea in the genital tract, gross salpingitis visualized at laparoscopy or laparotomy, an isolation of pathogenic bacteria from a clean specimen from the upper genital tract, or purulent pelvic peritoneal fluid without another source. The CDC guidelines for the diagnosis of PID in symptomatic patients is one of the following findings: a histologic evidence of endometritis in a biopsy, an imaging technique revealing a thickened fluid-filled tube with or without free pelvic fluid, or the presence of a tubo-ovarian complex, laparoscopic abnormalities which are consistent with PID, that is tubal erythema, edema, adhesions, purulent exudates, cul-de-sac fluid, or abnormal fimbriae. So coming to investigations that you would carry out for pelvic inflammatory disease, there are laboratory tests, there are microbiological tests, there are imaging tests, and there are surgical investigations. On laboratory tests, the first thing you do is a pregnancy test. Every female you see is pregnant until proven otherwise in the gynecological context. So you do a pregnancy test, particularly if the diagnosis of the PID is doubtful, so that you may exclude an abnormal pregnancy state. You must do a full blood count, complete blood count. You must do an ESR and then if you find it to be more than 60 mils per liter, that is suggestive of a tubo-ovarian abscess. You must do your C-reactive protein. You must do HIV screening tests, followed by appropriate counseling, and you should have obtained consent for that. You must do STI screening tests, and you should do a Papani Colau smear if there is no recent result of the smear. Microbiological tests that you can do: urine microscopy and culture, so that you may individualize the bacteria. Microscopic examination of the vaginal discharge in saline, and the cervical swabs to screen for chlamydia and gonorrhea. And then in imaging, you can do a transvaginal ultrasound, although it has a poor specificity for PID. You can do a Doppler transvaginal ultrasound. That one has a good sensitivity and a good specificity. And then, if still uncertain, you can then do a CT scan or an MRI. Surgical investigation, you can do a laparoscopy or a laparotomy. So differential diagnosis of what do you call, of PID. Then we have gynecological, we have let me group them according to the systems. We have gastrointestinal, we have renal, we have obstetric and gynecology related differentials. So I'll start with the obstetric and gynecology related ones because that's what's more relevant in obs and gynae. Ectopic pregnancy, dysmenorrhea, intrauterine pregnancy complication, and ovarian cyst, ovarian torsion, or an ovarian tumor. Those are the obstetric and gynecological differentials for PID. And then we have renal differentials. It can be cystitis, it can be pyelonephritis, urethritis, or kidney stones. And then we have gastrointestinal differentials, which may be appendicitis, cholecystitis, gastroenteritis, constipation, or inflammatory bowel disease. Coming to the management of pelvic inflammatory disease, this is a preventable disease. Appropriate counseling on the sexually transmitted nature of the disease, and advise against multiple sexual partner, to perform screening for other STIs, and doing HIV tests are part of the preventative measures that you can take against PID. You should give appropriate contraceptive advice. The patient must be counseled about the protective effects of barrier contraception against infection. The female condom also confers some protection from STDs. And also the IUD, Mirena, has been shown to reduce the risk of PID compared to the copper IUCD. And then if a patient presents with PID, you should contact and try to trace sexual partner or partners, if more than one of the patient, so that they can also be treated, so that they do not transmit the invaders. So coming to the treatment, the goals of therapy is to control the current infection and prevent infertility and other chronic sequelae. In the context of Gainsville classification, the therapeutic goals are as follows. So stage 1 and stage 2 of Gainsville, you can treat them as outpatients. And then stage 3 and stage 4 should be admitted for management. In stage 1, you are focusing on limiting symptoms of and infectivity. In stage 2, you are preserving the fallopian tube function. Stage 3, you're trying to preserve ovarian function. And in stage 4, we're trying to preserve the patient's life. So indications for hospitalization of a patient with PID, it should be acute PID with no sign of peritoneal irritation, suspected tuber-ovarian or pelvic abscess, pregnancy, a temperature of 38.3, an uncertain diagnosis, you admit that patient. If the patient also has associated nausea and vomiting, you admit that patient. Failure to respond to antibiotics within 48 hours, intolerance of oral medication, or patient seems to be unreliable with respect to follow-up, you admit that patient. So on outpatient management, you can give a mixed oral and parenteral regimen for the mild to mild to moderately severe PID. So due to the rising level of fluoroquinolone resistance against gonorrhea, the CDC no longer recommends its use for PID. So the recommended regimens is ceftriaxone, also known as Rocephin, 250 milligrams IM single dose, or cefoxitin, 2 milligrams IM, a single dose, with probenecid 1 gram per oral in a single dose. Other parenteral third generation cephalosporins such as cefotaxime, 1 gram IM in a single dose, plus doxycycline 100 milligrams per ounce twice daily for 14 days, with or without metronidazole, also known as Flagyl, 400 milligrams orally twice daily for 14 days. The addition of metronidazole may be considered in patients with proven or suspected infection with Trichomonas vaginalis or bacterial vaginosis, a history of gynecological instrumentation in the preceding 2 to 3 weeks. An alternative treatment regimen for PID may include levofloxacin 500 mg orally daily for 14 days, or floxacin 400 mg orally twice daily for 14 days, with or without metronidazole. So for inpatient management, general measures: you should hydrate the patient with intravenous infusion of fluids, give adequate analgesia, regular monitoring of their blood pressures, pulse rate, respiratory rate, temperature, urine output, etc. Serial assessment of systemic, abdominal, and pelvic signs. And then on medical therapy, you do parenteral therapy with cefotaxime every 6 hours, that is 2 grams IV, and or cefotetan 2 gram IV every 12 hours, plus doxycycline 100 milligrams IV or per os every 12 hours. You can also use clindamycin 900 milligrams IV every 8 hours, plus gentamicin only if the patient is not renally impaired or does not have diabetes. Loading dose of 2 milligrams per kg of body weight, followed by a maintenance dose of 1.5 kg per 1.5 milligram per kg of body weight every 8 hours. Also use ampicillin sulbactam 3 gram IV every 6 hours with doxycycline 100 milligrams IV or per os every 12 hours. In South Africa, the following regimen is often used in most facilities. They use ampicillin 1 milligram every 6 hours, gentamicin 240 milligrams daily, metronidazole 500 milligrams every 8 hours. So the response to therapy is determined by the following: a reduction in abdominal tenderness, a reduction in temperature spikes, a decrease in the size of tubo-ovarian complexes that were assessed by ultrasound. Surgery: laparotomy is indicated in the following situations: generalized peritonitis, tubo-ovarian abscess which does not respond to appropriate antimicrobial therapy within 48 hours, a pelvic ultrasound, a pelvic abscess which is pointing into the vagina, rectum, or abdominal wall, and as uncertainty about the diagnosis. So the following principles should be adhered to in surgical management: correction of dehydration, anemia, and acidosis, use of appropriate broad-spectrum antibiotics. The extent of the surgery depends on the extent of the disease, the general condition of the patient's age, parity, and desire for future fertility. In patients who desire fertility, consideration should be given to a unilateral adnexotomy. The following surgical procedures may be performed: an ultrasound directed aspiration of pus collections, posterior colpotomy may be performed to drain the pus. You may do a laparotomy, and you may do a second look repeat laparotomy. The second look repeat laparotomy is beneficial in generalized peritonitis where several packets of pus were found, paracolic or subphrenic abscess, doubt about perfusion of the uterus in a patient who has completed her family. So follow-up care should include review of patient in a week, post-hospital discharge, confirmation of medication compliance, reiteration of PID preventive strategies, and confirming the treatment of the sexual partner or partners of the patient. Sequelae of PID, its recurrence, infertility, ectopic pregnancies in the future, chronic pelvic pain, psychological sequelae, and mortality. Now we're going to talk about HIV and PID. HIV-infected women have more frequent episodes of PID compared with uninfected women. HIV-positive women usually have other coexisting infections such as mycoplasma, candida, streptococci, and HPV infections. Chronic PID is another subheading. It's the end result of acute PID. Tubal anatomy is then distorted by the presence or existence of adhesions and fibrous tissue. A frozen pelvis is present. Symptoms include backache, lower abdominal pain, secondary dysmenorrhea, and excessive malodorous vaginal discharge, and menorrhagia. Infertility is not uncommon in this patient. Management includes analgesics, non-steroidal anti-inflammatory drugs, antibiotics, and occasionally surgery. The surgical indications include recurrent attacks of PID, persistent symptoms, persistent pelvic mass, and uncertain diagnosis. Now, there is another subtopic that I'd like to go through. It's genital tuberculosis. In the pathology of the genital tuberculosis, the fallopian tube and endometrium are commonly invaded sites. The microscopic appearance of the various structures is as follows. The fallopian tubes are involved in 90% of the cases. The appearance is variable. It may be normal, they may appear edematous or hyperemic. Tubercles may be present, lamina closed in 50% of the cases. Hydrosalpinx or pyosalpinx may be present and may present rigid and calcified and may occasionally appear carcinomatous. The uterus usually appear normal. Pyometra and myometral abscesses may occur. The ovaries are infected in 30% of the cases. They may appear normal. Adhesions and tubercles occasionally do occur. And caseating granulomata occur with hematogenous spread. In the cervix, a friable ulcerative lesion which may be confused with a carcinoma may be visible. In the vulva or vagina, is a typical presentation with a shallow superficial tender ulcer with an undermined edge, induration and edema sometimes present, and other non-specific features. So the diagnosis is a clinical diagnosis. Symptoms, you hear the patient giving you a history of tuberculosis, positive contact with a TB patient. Infertility is the most common symptom in 70% of the cases. Chronic lower abdominal pains, abnormal uterine bleeding in 50% of the cases. Amenorrhea, watery and or blood-stained vaginal discharge, and constitutional symptoms. Signs, there may be no clinical signs. Chronic ill health, lymphadenopathy, abdominal signs such as tenderness, a doughy feeling on palpation, ascites, a lesion on the vulva, vagina or cervix, an adnexal mass in 15 to 45% of the cases, and tender and thickened uterosacral ligaments. So investigations that you can do a diagnostic dilatation and curettage, that is DDNC. It should be performed towards the end of the menstrual cycle. It's important to curettage the region of the cornea. Menstrual fluid collection, especially in day 1 and day 2 of the menstrual cycle. Endometrial cavity of aspiration. There's also a number of investigations that can be taken, such as a chest x-ray for evidence of old, active or healed TB, an abdominal x-ray to look for calcifications of lymph nodes which will be suggestive of TB. Hysterosalpingogram is not routinely recommended, but if the diagnosis is uncertain, you can go for it. Tissue biopsy and cervical cytology. You can do tuberculin testing, pelvic ultrasound to detect tuber-ovarian masses. You can do a laparoscopy. It's not recommended, but because of the possible complications. But if the diagnosis is uncertain, that's the way to go. And you can also do a laparotomy, which is a safe method of obtaining tissue diagnosis in doubtful cases. Management, the following management principles should be applied. You exclude an extragenital source of infection. You exclude coexisting urinary TB. You provide dietary advice. Admit if the extragenital disease is active. 6 months of standard treatment for TB, provided that it contains rifampicin. Undertake endometrial sampling following the completion of treatment, and surgery is considered in patients who have a failed appropriate response following the above mentioned therapy, recurrence despite appropriate medical treatment, a persistent pelvic mass and chronic pelvic pain, persistent symptoms, or menorrhagia. Follow-up is done annually for a minimum of 5 years in this patient. Thank you, and see you soon again. In the next few topics, we'll do other gynecology and obstetric topics. So take care.